This is Dr. Talal Nakkar. I'm going to talk about high frequency oscillatory ventilation. Will be first part of the presentation. I'm talking about basics. I will cover the second part, will be the setting, and the third part will review the evidence. This presentation is the 35th on the series of mechanical ventilation. I used to talk in Arabic for some reason. Today I will present this presentation in English. Just to let you know, for the one who doesn't know what I'm talking about, this is the machine we are talking about, the high frequency oscillator. So it is different than the usual mechanical ventilation, the conventional machines. It has different settings, different theory. We are trying to cover this machine in this presentation. So I will start with talking about ventilator associated lung injury. We used to talk about overdistension and atlantic trauma, the opening and closing, the low tidal volume ventilation, and the high tidal volume ventilation, the overdistension. Both can cause ventilator associated lung injury. So the optimal range will be in the middle. We avoid the overdistension and we avoid the low tidal volume ventilation. So again, ventilator associated lung injury is caused mainly by two things: overdistension, that's during inspiration, maximum very high tidal volume, and the atlantic trauma, opening and closing, opening during inspiration and closing during expiration, that will cause shearing stress, will cause increasing the stress. Maybe we cover it in other presentation. So that will be prevented by applying beep. So very low tidal volume, very high tidal volume, both can injure lungs. So lung protective strategy depends on preventing overdistension by applying less volume, low tidal volume ventilation. We talk about it in ERDS presentation. We can review it back. And preventing atelectasis by applying higher beep. That will prevent the low tidal volume ventilation, and that will also decrease the lung injury. So that will come to the concept of the high frequency ventilation. If we keep the lung open during inspiration and expiration, that will cause less overdistension during inspiration, and that will prevent alveolar collapse during expiration. So instead of giving high tidal volume and low tidal volume, so I'm just doing I'm keeping the lung open by applying positive pressure, which is the main airway pressure. We can talk about it in the next slides. And the ventilator will oscillate around this pressure. So mainly we keep the lung open, we keep the alveoli open, preventing overdistension and underinflation. So this pressure time waveform will compare the conventional pressure control ventilation with the high frequency waveform. You see here we start with the beep of 10. We go up to during inspiration to the maximum inspirative pressure, which is the plateau pressure here. Then we go back to the low tide, the beep level, again to the plateau pressure, then to the beep level. So you see here that the main airway pressure is around 25. In the high frequency oscillatory ventilation, we can apply main airway pressure directly. You see we are applying higher map here, and the ventilator will oscillate around this map, up and down, and that will still be less than the maximum inspiration here, maximum the plateau pressure, and higher than the beep level here. It's around 23. So you see that the ventilator is applying higher map with less overdistension and avoiding underinflation. You see here the conventional mechanical ventilation. During inspiration, the alveoli are open. During expiration, you see almost collapsed. While on high frequency inspiration ventilation, the inspiration, you see the alveoli are opened, and during expiration, it's still open. This is by electron microscope. Again, during inhalation, we applying tidal volume. We increase the pressure in the air till it reaches the plateau pressure. during expiration the volume will decrease. So there is big difference between inspiration and expiration. While in high frequency oscillator, we are applying direct pressure, which is the main airway pressure. We keep the lung open and then we shake it by the frequency we are applying. So theoretically, high frequency will prevent overdistension. This is the operating zone of the high frequency, so we are avoiding the overdistension and we are avoiding the de-recruitment and the atelectasis, which is atelectic trauma. So we avoid overdistension, we avoid alveolar collapse. Theoretically, high frequency oscillator will protect the lung more than the conventional low tidal volume high beam. That's what we think. When we review the evidence in the last presentation, the third part, we'll see that all of this theory proven to be wrong in the practical life. We'll talk about it later. So high frequency oscillation, we are applying a constant pressure on the alveoli to keep it open, which is the main airway pressure. In order to facilitate gas exchange, we make airway pressure oscillate rapidly around the baseline pressure level, which is the main airway pressure. That will allow for oxygenation and ventilation in different mechanisms. That's what we call decoupling of oxygenation and ventilation. On this machine, I can manage oxygenation without affecting ventilation, and vice versa. On conventional mechanical ventilation, if you apply some setting to improve oxygenation like beep, ventilation might be affected, and if you apply some change on ventilation like applying higher tidal volume or less tidal volume, oxygenation might be affected as well. Here in this machine, it's decoupled. Ventilation is different than oxygenation, different mechanisms. So basically, high frequency oscillatory ventilation can be viewed as a means of delivering CPAP with the built-in shaker to facilitate CO2 elimination. This is simple circuit like CPAP circuit. We are applying constant flow, we call it bias flow. Through this circuit, here we have adjustable valve. We'll increase the pressure till we reach the MAP pressure, what we call main airway pressure, like the same as CPAP concept. This is connected to patient, and that will provide oxygenation, constant flow of oxygen. That will provide the oxygenation same as CPAP. How to facilitate CO2 removal? Here we are connecting this circuit to a shaker. Piston can cause high frequency waveform, in and out, and that's the basic concept of the high frequency oscillation. This piston is like the speaker we used to know. This will generate high frequency waveform, and that we call the voice we hear in this device. Same here, but this is applied on the circuit to facilitate CO2 removal. So before starting the oscillation via the piston, the circuit works as CPAP circuit. The bias flow, the constant airflow we are applying to the circuit, we supplied air around 20 to 40 liters per minute. In pediatric, we use 20 liters per minute. In adult, we use to have 40 liters per minute. The MAP is the CPAP level. It's adjusted directly. We have range from whatever we decide, and this is different than conventional mechanical ventilation. On conventional mechanical ventilation, the MAP is the result of the applied tidal volume, the applied beep, the applied inspiratory time. Here the MAP we adjusted directly, and that's the advance in these modes. The FiO2 can range from 21% to 100%. So when the piston starts to oscillate, the gas is pushed into the lung during inspiration and then pulled out during expiration. So that means inspiration is active. This is like conventional mechanical ventilation. We push air in. Expiration is active as well. This is different than conventional mechanical ventilation. Conventional mechanical ventilation, expiration is passive. Depends on the passive recoil of the chest wall and the lungs. Here we pull the air out in this machine. So in high frequency oscillator, we use very small tidal volume, less than dead space ventilation, around 1 to 3 ml per kg. We use very high rate, 180 to 900 breaths per minute. Just remember that 1 Hertz is 1 breath per second. So 1 Hertz is equal to 60 breaths per minute. So we use a frequency around 3 to 15 hertz. 3 hertz mean 3 multiplied by 60, so it's 180 breath per minute. And 15 will be 15 multiplied by 60, so it will be around 900 breath per minute. Just compare that with the conventional mechanical ventilation. The maximum rate on ERDS patient is 35 breath per minute. So let's talk about the waveform. So this is the high frequency waveform. The ventilator or the oscillator will oscillate around the map. This is the main airway pressure. So the map is the it's compared with the 0. So this is, let's say, 35. This is the main airway pressure. So this is the waveform. We have the amplitude. We have the TI, the inspiratory time. We have the frequency. So T will be 1 over frequency. So frequency is how many cycles per second. Amplitude, which is delta pressure, or we call it power sometimes. So it's the amount of power that is driving the oscillator piston forward and backward, resulting in an air volume displacement. TI fraction or TI percentage is the percent of cycle time the piston is traveling forward. So here the piston is moving in and out, so the maximum is the amplitude, the time which is spent in the inspiration and time spent in the expiration. This is the TI percentage. And the frequency, how frequent this piston is, this diaphragm is moving in and out per second. This is the hertz. So tidal volume is very small, could be less than dead space, as we said. It's determined by 3 settings. 3 settings can decide how much tidal volume is applied. The frequency we choose, the amplitude we choose, the inspiratory time percentage. So here again, this the waveform of high frequency ventilation. Here we have the main airway pressure. So delta pressure is 70 here. The inspiratory time here around 50%, I can see, or less than 50, maybe 50%. And the hertz, how frequent the diaphragm is moving in and out per second. So how to increase stroke volume? I mean, how to improve ventilation. So if we increase this is the waveform, and this is the amount of air coming in and out. So if I increase the amplitude, that will increase the tidal volume. If I decrease the frequency, that will increase the tidal volume. So that's different than the conventional mechanical ventilation. In conventional mechanical ventilation, I used to increase the rate to improve ventilation. Here we have to decrease frequency to improve ventilation. This is big difference between high frequency ventilation, oscillator, and conventional mechanical ventilation. Even for the inspiratory time, if we increase the fraction of inspiratory time, that will improve the ventilation. But rarely we do it in the real life. So in high frequency oscillation, tidal volume is very small, less than dead space. There is other mechanisms for gas exchange comparing with the conventional ventilation, the direct ventilation. In conventional ventilation, the air will come in and out based on the driving pressure. That's what we call the convection. Here in high frequency, there is other mechanisms. The diffusion, it's other mechanism. We'll talk about that quickly in the next slides, which is beyond the scope of this presentation. Even the minute ventilation, it has different formula. Minute ventilation is equal to frequency multiplied by tidal volume power 2. So here we can see there is many mechanisms for gas exchange. You see this part is the convection, which is difference in pressure. The other part is the diffusion. So asymmetrical inspiratory and expiratory velocity profile on inspiration, velocity profile on expiration, collateral ventilation, laminar flow and radial mixing, Bendel-Loff effect, turbulent flow and radial mixing, direct ventilation of closed alveoli. This part is convection, this part is diffusion, and this part is convection and diffusion. So I will go through these mechanisms quickly. If you are interested, you can follow this review. It's a very nice review, 2005, in critical care medicine, about the mechanisms of gas exchange and lung mechanics during high frequency. We have the bulk flow, like which is convection, like conventional mechanical ventilation for the proximal airways. We have Bendel loft effect. We have Tyler dispersion. We have asymmetrical velocity profile and cardiogenic mixing, collateral ventilation, or all are different mechanisms for gas exchange during high frequency. What about work of breathing during high frequency? We used to talk about elastic work and frictional work in conventional mechanical ventilation. Elastic work for the lung parenchyma and frictional work for the airway mainly. So this is the elastance or the compliance issue, and the frictional work which is the resistance. There is third part, which is the inertial work. Here in high frequency it's important. We used to ignore it during conventional mechanical ventilation. So again, the elastic work, the work is to overcome the lung elastic recoil, the thoracic cage displacement, the abdominal organ displacement. Frictional work to overcome airflow resistance, which is the major part, and the viscous resistance, which is low friction, which is minor part. What about inertial work? Inertial work is the work to overcome the acceleration and deceleration of air, acceleration and deceleration of chest wall and lungs. It's negligible during conventional mechanical ventilation, but cannot be ignored during high frequency ventilation. So let's talk about inertia. It's the property of a matter by which it remains its state of rest or its velocity along a straight line. It is the tendency of objects to keep moving in a straight line at constant linear velocity. In high frequency oscillation ventilation, tracheal tube accounts for approximately 90% of inertance. So equation of motion will be different. So pressure will be pressure, elastic pressure, resistance pressure, and inertial pressure. So the formula will be pressure, it will be equal for elastance multiplied by tidal volume plus resistance multiplied by flow rate plus inertia or inertians multiplied by acceleration rate. So if we apply delta pressure of 70 to 90 centimeter of water at the level of the ET tube, the pressure which will reach the alveoli, it's the main airway pressure plus minus 10% of the delta pressure at the alveoli level. So again, here this is the delta pressure applied at the ET tube. Because of the inertia of the ET tube, it will be decrease gradually till it will reach 10% plus minus of the main airway pressure. So even if I'm applying 90 centimeter of water at the airway pressure, which is really high, it does not reach the alveoli. Again, this is the oscillation, delta pressure or the amplitude or the power. You see it's decreasing gradually. Here is the endotracheal tube, here is the carina, here is the segmental bronchi, here is the alveoli. Gradual decreasing of the pressure. This is the inertia effect. So I'm applying the same map in high frequency. You see the map is the same, but the delta pressure is decreasing gradually, but map is the same. Comparing with the conventional, the same pressure is applied for the whole airway. That's the difference between the high frequency and conventional, and that's what we think it's more protective for lung. That's what we think, but the real life is different. So here again, the delta pressure, this is for the amplitude on the airway, while here is the main airway pressure and the delta tidal volume on the alveoli. So repeating the same issue, we applying high pressure, high delta pressure on the alveoli, on the airway level, and it's gradually decreasing, but the same main airway pressure will be kept on the alveoli. So percentage of pressure transmission will be affected by, it will decrease a lot with decreasing endotracheal tube diameter. It will decrease with the increase in frequency. So we used to have higher frequency. We used to apply higher frequency, or we prefer to apply higher frequency to decrease the transmission of pressure. It decreases if the lung compliance increase. It decreases if the aerated volume increase. Same concept as compliance. It decreases with the introduction of cough leak, and it decreases with the tracheal gas insufflation, and it will decrease with the increased length of the ET tube. Is it risk-free, this machine, the high frequency ventilation? No, it's not risk-free. There is lack of effective alarms, making the diagnosis of life-threatening condition difficult. Tension pneumothorax, if you have unexplained hypoxemia, just think about pneumothorax. Do an x-ray and look for the pneumothorax for this patient. Tracheal tube obstruction, if you have unexplained hypercapnia, CO2 is really high suddenly, so think about tracheal tube obstruction. And there is no alarm to tell there is this is the problem. And other problem with the high frequency machine, that you cannot transport patient, like let's say you want to do some procedure, some CT scan, you cannot transfer the patient with the high frequency ventilator. Here we reach the last slide of this presentation. Thanks for watching. We already covered the basic concept of high frequency oscillation. We'll talk about settings next presentation, and finally we'll review the evidence. Just remember to subscribe to this channel, and thanks again for watching.